Good afternoon and welcome to today's webinar, Payment and Delivery System Reform 101. I'm Georgia Maheras, the Vermont Healthcare Innovation Project Director, and I also serve as the Deputy Director for Healthcare Reform for Payment and Delivery System Reform at the Agency of Administration. I will be presenting this afternoon's webinar. This is the first event in a series of Vermont Healthcare Innovation Project's new webinars. These will be occurring monthly on the second Wednesday for all of 2016. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. If you're listening using your computer system by default. If you would prefer to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. We have a few housekeeping items before we get started. We have set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to me by typing your questions into the questions pane of the control panel. You may send your questions at any time during the presentation. During the Q&A portion of today's webinar, Sarah Kinsler will read participant questions aloud for discussion. Today's event is being recorded. The slides and recording will be posted to the VHCIP website within the next few days. You will be notified when these materials are available. At the end of today's event, you will be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank several individuals for planning this webinar and taking charge of logistics. Chrissy Geiler and Sarah Kinsler have been remarkable in making sure we got this off the ground. Additionally, I wanted to thank Kara Suter, Anya Rader-Wallach, and Ina Backus for creating many of the slides that you see as part of today's presentation. And now I think we'll move on to the webinar itself. On slide 4, the slide on your screen, is today's agenda. We're going to be talking about 3 basic areas. First, what is payment and delivery system reform? Why are we doing it and why should you do it? And what lessons has Vermont learned so far? I think we all know why we're doing payment and delivery system reform. We want better care, better quality, and lower cost growth for Vermonters. While Vermont consistently ranks in the top 1, 2, and 3 for our per capita health, we can do better. And in particular, we can do better with certain populations and in certain parts of the state. We also have had fast cost growth over time and until recently outpaced the overall U.S. healthcare cost growth trend. Our cost growth year over year far outstrips state domestic product growth. Vermont's cost experience is mirrored nationally. Other states and Medicare have experienced cost growth that exceeds inflation. Additionally, when compared to other industrialized nations, the United States population health compares poorly to other countries despite this increased expense. Because of this, there are 21 other states engaged in state innovation model testing grants, with another dozen engaged in various payment and delivery system reforms. Medicare is taking the lead as a payer and is moving Medicare payments away from fee-for-service to value-based payments with aggressive goals over the next 5 years. This next slide just describes Vermont's delivery system and really sets the stage for the types of reforms we are engaged in Vermont. Depending on where services are delivered and who delivers them and the population they are serving, our models are designed to address all of that. Moving on to the next slide, we've identified several building blocks to a successful payment model in Vermont. First, you need to have the appropriate health data infrastructure. This means that we need to make sure that we're sharing information between payers and providers, between providers and the state, between payers and the state, and really making sure that that information is up to date and of high quality. We also need to make sure that providers are ready and that they have the tools to transform their practices from those that are based on generating volume to those that are generating value. Tools that we employ in this area include care coordination, patient-centered focus, and participation in regional and community collaboratives. These 2 areas of health data infrastructure and practice transformation lead to our provider and payer readiness assessment. Once we've determined that providers and payers are ready, we then move on to a payment model design and implementation. Provider and payer readiness is assessed in several different ways. Specifically, we look to see if there's a willingness by the payer and the provider to engage in a transformation activity. We also look to see if the data infrastructure is available and if there's an opportunity for improvement on either the quality side or the payment side. The ultimate objective of any payment reform is to motivate behavioral change that would lead to lower costs, better care coordination, and better quality. Providers will be better able to achieve these objectives if it's clinically meaningful, it will impact their patients, and if we're able to communicate information to the clinicians about what is going on with their patients, with the care that they're delivering, and with the quality they're achieving. What does this mean for beneficiaries? Most importantly, the programs that we design are intended to improve beneficiary outcomes and increase the value of care. We're promoting accountability for the care beneficiaries. We're requiring coordinated care for all the services that are provided. We're encouraging investment in infrastructure and redesign to avoid those day-to-day hassles that are big and small that impact Vermonters. Our programs do not limit patient choice, and importantly, the programs are iterative, and we require collaboration from consumers, consumer advocates, providers, payers, the state, and many other stakeholders. To pop back into our current system, or the system we're in the middle of leaving, right now we have misaligned financial incentives. For example, fee-for-service. This is across payers and providers and has led to significant fragmentation in both our medical and social systems. Our goal is that we're going to link the financing, the dollars we spend, to the value of what those are being spent on to fill gaps and strengthen our overall system. Currently, we get what we pay for, as in everything. Right now, we have a limited amount of accountability about the range and types of care that patients receive. The fee-for-service system is not designed to report out on that accountability or to provide incentives regarding that accountability. We have limited payments for coordination of care across clinicians and providers or over time. There's limited incentives for improving quality and reducing costs, and there are no incentives for constraining the volume of care. In a nutshell, fee-for-service lacks many positive incentives and includes many negative incentives. A new payment system should avoid the negative incentives created by the fee-for-service system. Really, it's to be the flip side of the previous slide. We want to encourage accountability across the range of care and support services. We want to incentivize coordinated care among all providers and clinicians. We want to have an incentive to improve quality and reduce costs. And we want an incentive to use resources efficiently. The next slide shows the continuum of organization for payment delivery system reform. If you're looking on the left hand of the slide, the y-axis kind of shows a progression from linking payments together, starting with fee-for-service, which is the most disaggregated way of payment, up through a full population prepayment, such as a capitated payment arrangement. And we'll talk more about those details later. On the bottom, you can see that depending on the style of clinician organization or provider organization, they are more or less able, without giving them significant tools, to handle different types of payment arrangements. So smaller practices and entities that are not affiliated have difficulty handling the risk and the complexity of a capitated or full population prepayment. Alternatively, fully integrated delivery systems are more able to handle that. Our goal through our payment reforms in Vermont is to move the bar. So as you'll see, we're scrolling through from a lower gray bar to a higher gray bar. And as I said, our goal is to really get the entire healthcare system to an area where providers are more accountable, are able to handle more care coordination, and are confident in their ability to deliver the right services to Vermonters. We're looking to transition from pilot payment reform models to a broader scope over time. At the bottom of the slide, we're building on several key aspects. As I've indicated, we're moving away from fee-for-service. We're building on our successful Blueprint for Health patient-centered medical home initiative. We're trying to do everything in a multi-payer basis as much as possible. This means all commercial payers, Medicare, and Medicaid. And critically important is incorporating performance measures for cost, quality, and patient experience across any model. Excuse me. Looking at the top of the slide, just for some examples, we have bundled payments that would progress to a population-based payment. Bundled payments, again, as we'll talk more later, talks about a limited population and selected diagnoses. Moving down the slide, the hospital and physician budget to population-based payment, again, these are looking to say, how can you take limited services with a larger population? And then finally, at the bottom, you would progress to all services and a larger population. I want to take a moment to talk about what Medicare is up to, because as I said, this work is happening all around the country. Vermont is not unique in it, and frankly, this is what's going to occur in the healthcare sector for several years to come. Right now, Medicare has many, many different payment model initiatives, and I provided the hyperlinks so you can look at all their different ongoing initiatives. But in particular, I wanted to highlight the ones that are active in Vermont. So they have 3 different types of financial sharing arrangements: Pioneer, Shared Savings, and Next Generation, that rely on accountable care organizations. They also have a robust episode of care program that began as a VHCIP program and has now expanded to many other types of bundled payments. They have a primary care transformation area of work, which for Vermont is the MAPCP program, but has a different name in other states. And then they also have individual models such as the hospital-based value-based purchasing, avoidable readmissions, etc. for folks. And Medicare just rolled out a series of new payments that will impact both hospitals and physicians over the coming years that transform more and more of their payment models away from fee-for-service and towards these value-based reforms. Looking ahead a little bit to what Medicare is going to be up to over the next several years, we have a look to say they're phasing out fee-for-service schedule updates, and these are the physician payments I just referenced. They're phasing out the increases to their basic Medicare fee-for-service fee schedule, and instead relying more heavily on quality improvements and quality components for payments and payment increases over the next several years. If you look in the middle row at the yellow arrows, there's a combination of activities that Medicare is looking at, including quality measurement, clinical practice improvement activities, resource use, and the meaningful use of certified electronic medical record technology. Additionally, there's also all-payer models that they are looking to implement over the next several years, and those also have a specific type of incentive program that Medicare is working towards. So as you can see, Medicare is intentionally phasing out increases on their fee-for-service side and ratcheting up the increases on the quality improvement and the value-based purchasing side. In Vermont, we have several different types of new payment models, and I've ranked them in order of risk-bearing, so from the least amount of risk for a provider to take on to the most amount of risk. And critically important is with any of these payment models, and a differentiating factor in this wave of payment reforms compared to those that came in the 90s, is that all payments are linked to quality of care measures. It is impossible for it to be a modern payment reform if no quality is measured. So starting with pay for performance, in Vermont we have Medicare's participation as well as commercial and Medicaid in our Blueprint for Health patient-centered medical home as our signature pay for performance program. Building on that, we have a health home initiative that's referred to as the hub and spoke within the state that is also at its heart a pay-for-performance model. We have shared savings programs. We have ACOs that are participating in the Medicare program, as well as ACOs participating in a Medicaid and commercial program. We have a handful of episode of care programs, bundle payments. So we have some providers who are participating in Medicare episode of care programs, and also in commercial carrier episode bundle payment programs. Finally, we do have a handful of capitation type payments that are still being made, mostly within Blue Cross as a commercial carrier, but this is really more looking towards the future of what could potentially happen in Vermont. As I indicated, the risk to the provider increases as you look at each of these payment models. And I want to be clear that I called out a subset of types of payments. This is not the entire world of payment models. If any of you do research, you'll see that there's approximately 30 different types of payment models that you could use and different jargon you could use for them. But I want to focus on the ones that are in play in Vermont or are coming down the pike. So focusing for a minute on the SIM models and comparing them, as I said, we've got an ACO-based shared savings program. We've got an episode care program that is in design, and we also have launched pay-for-performance work. As you can see, some of the differences between these include who is being impacted. Is it an individual site of service or an individual practice, or is it an entire population? Is it that providers are accountable for a broad set of services, or is it they're provided for a narrow set of services related to a particular condition? And finally, what's the relative resource use, and what are the carrots and sticks inherent in each of these models? So moving on to the next slide, Pay for Performance is a program that starts with a fee-for-service based payment and adds incentive payments on top of that. So at its most kind of in a simplistic manner, it really is about giving carrots. So a provider reaches a certain goal and gets a carrot. A provider reaches a higher goal and gets 2 carrots. A provider reaches the highest goal, gets a bunch of carrots. So it's a pretty simple performance reward program design. What's really important about this particular program design is that, like with any of the other payments, the information we give back to a provider is critical for them to be able to achieve the higher levels of performance. We need to be able to give them information and data about how their patients are doing, how they are doing, and how the quality is being measured and the performance that they're giving. Moving on to the next slide, as I indicated, health homes in Vermont are built off of our Blueprint for Health pay-for-performance model. Again, fee-for-service is the base payment, but this really taps into a very specific federal Medicaid opportunity within the Affordable Care Act. It looks at a specific set of conditions, a specific type of eligible patient, and really requires a high level of integration and coordination. And in Vermont, that's our Hub and Spoke initiative. Moving now to the shared savings program, where there's an increased amount of risk. Again, though, our base payment is fee-for-service, and then there's a retrospective look back on the claims paid to see if an ACO beat the target or not, if they achieved a sufficient amount of savings, if they met quality measures, and if those savings should be shared between the payer and the provider. Ultimately, it's a performance-based contract between a payer and a provider that sets forth a value-based program to determine these shared savings between the parties. Here's how it works. People see their PCPs as usual. If their PCP happens to belong to an ACO, the ACO accepts responsibility for the cost and quality of care provided to that person within the services agreed upon in that performance-based contract. The providers bill fee-for-service as they usually do, and then there is that later look back. There are 2 different aspects to how a shared savings program can work. There are shared savings programs where there is no downside risk, so an upside only or gain sharing arrangement, where basically an ACO is at risk for only not getting a certain amount of money, but they don't have to pay back any money if they go over certain targets. And then there's the downside risk option where an ACO could achieve savings, so achieve some additional dollars, or have to pay back. In Vermont, we do not have any ACOs participating in a downside risk model. However, there are several ACOs across the country participating in Medicare's version of this program. And the data are early, but about half of the ACOs achieved their financial targets and half of them did have to pay some resources back to Medicare. Moving on to an episode of care. An episode of care is where we start to get a little complicated in terms of what the base payment can be. So the base payment for an episode of care can be fee-for-service. It can also be something called a DRG, which is a pretty complex calculation that the folks at 3M invented in the 80s and are still using for many hospitals and Medicare payments. Or it could be a different alternative type of base payment. I want to note that for the shared savings program, episode of care, and other payment arrangements that we have, that the payment amount that is set is based on the claims that were paid. So you do look at historical trends to set your rates. It's just how the money is paid for. Does the provider get the money in advance or at the end impacts how the incentive is structured. So what's an episode of care? It's all the related services for one individual with a specific diagnostic condition, and it's basically from the onset of symptoms until the treatment is complete. So what we're doing is we're aggregating payment into clinically meaningful episodes. This is really critical. This is episodes of care are very complex to design and require a significant amount of input from providers to ensure that they're clinically meaningful and that we're putting the right package together of services that are meaningful for them. You can then layer on a bundled payment that would reward quality of care and introduce a level of risk to providers. For example, an episode of care could be around a knee replacement, which is for a certain time period and includes very specific types of services. Alternatively, it could be an ADHD-related episode, which would be for a time period and certain services that occur within that time period. The way an episode works is there's an acceptable performance range, and then there's the kind of bare minimum range, and then there's the you did better than everyone else range. The kind of what you're looking at is arraying a provider's performance to make sure that they're really delivering the care at a high enough quality level, and then working with them to improve that quality, and the financial incentives are linked to the quality. Moving on to capitation. Capitation is a per member per month or other population-based payment rate. So unlike the payment models we've been talking about so far, this one is very much driven by the population and less by the specific services that someone is experiencing. The providers take on the risk for a whole population for a set of services over a defined period. As I said, the payment is based on the person, not on the services. Importantly, there can be payments underneath the capitation level to encourage higher value care. And the risk arrangements vary depending on the payer and the relationship they've engaged in with the provider. For example, Medicare, through their next generation model, has a few different types of risk arrangements that allow a provider to accept either 100% risk or something less than that to make sure that they're able to take on that risk and that there's no, that they have a minimal amount of concerns about ensuring quality to the beneficiary. Some lessons learned. As I mentioned at the top of the presentation, provider readiness is critical. You can only make change happen so far as a payer or as a state if you don't have a provider who's willing to work with you. We are very privileged in Vermont to have a broad swath of providers who are willing to work with us. Data drives all of these changes. So not just the data that we're providing back to the providers, which is critical for responsiveness, we also have data that helps us evaluate where and how these payment models can be improved. We also need to make sure that we're not overburdening the system by having inefficient data systems. So as I mentioned earlier, a key piece of what we're trying to do is making sure our health data infrastructure can support the health system of our future. Any payment model takes time to design. These are not easy to develop, and they require a combination of public and private entities to develop. As I like to say, if this was easy, we would be done by now. Payment model design also requires technical skills and an understanding of the current payment arrangement and the goals for the future. In general, for the payment models that we work on, we have to start with what's our current set of services, what is our current set of providers, how do we currently pay them, what are the programmatic rules, and what could we do in the future. There is no presumption that any one type of payment model is the, quote, best one for any set of services and any type of provider. That is really driven by a lot of collaborative work and a lot of conversation and a lot of data analytics to make sure that we're creating the right type of incentive to drive the behavior that we're looking for. This is all about systems and behavioral change. We're not trying to kind of point fingers at anyone, but really recognizing that we have a system we have because we built it in the manner we built it. Now we're working to redesign it in a way that improves the quality of already high quality within Vermont while mitigating some of those cost trends that we're experiencing. We will now take questions from participants. As a reminder, you can submit questions by typing into the questions pane of your webinar control. Sarah Kinsler will facilitate our Q&A.
Thanks, Georgia. We'll now begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your GoToWebinar control panel. Our first question is, what exactly is a payer and provider readiness assessment? Is it actually being measured? Is it a feeling? How do we know that providers are ready?
Great question. So it is both actually being measured and a feeling. I think from my perspective, a key piece of provider readiness is a provider's willingness to come to the table and work really hard to develop an alternative payment model. So that's some of the feeling and willingness. We also have some measurement tools that we use in terms of provider readiness. And those include looking at the existing payment method for that provider and ascertaining the level of accountability and risk they're currently experiencing. We also look at their data systems and, frankly, the state's data systems and other payers' data systems to see if they have a sufficient amount of ability to get to where they need to in terms of data systems, or if we need to do a lot of work to prepare them. So it's a combination of that, and we actually have 6 steps that we go through before we decide to launch, 6 formal steps before we decide to launch a payment model in any area. And we have a report that PHPG helped us with last year that we rely on for that.
Thanks, Georgia. And a follow-up question we've gotten from a participant is, can you tell us about some of the things that SIM as a program and the state in general is doing to support provider readiness, increase provider readiness?
Yes, I would love to. So this is an area where I would say we have far exceeded my expectations in terms of our ability to deploy tools to support provider readiness. So we have a whole bunch of different areas of work that are intended to support different sectors of providers. We started with a statewide learning collaborative that actually started in 3 pilot communities and is now in 11 communities. And this really looks at core care management services and bringing together care managers from around the state. We also have a sub-grant program with 12 sub-grantees that are doing individualized practice transformation support, depending on the type of project, that really provides either technical assistance, dollars, additional staffing, you name it, whatever they need to really take them from idea to that transformed state. We have regional collaboratives, and these were built on the Blueprint for Health Community Health Team infrastructure, and really set up within each of the 14 health service areas. We set tables, frankly, where we invite community health teams, accountable care organization representatives, community providers, local state agencies to work together, to come together to figure out how to improve the quality within their region. Finally, we've done some other work around ascertaining what might be next and what else we might need. And we've heard that there's some gaps in training, particularly around care management core competencies and around core competencies to support individuals with disabilities and in need of long-term services and support.
Thanks, Georgia. We've had a couple of questions from participants about episodes of care. First, we'd like to hear more about how provider relationships are balanced within episodes. So how does the PCP, specialist, hospital relationship work? And another question about episodes is around how episodes can work for chronic conditions. You give the example of ADHD, but I think folks would like to hear a little bit more about that.
Sure. So the relationship for an episode of care usually ends up with one person or one entity being the kind of most responsible entity for that individual's care. So I'm going to use an example of a chronic condition where you could apply an episode and give the example of how the relationships work. So if your chronic condition that you're looking at is diabetes, and you are looking to improve the quality of care for diabetes, and you're bundling together the primary care services, and you're bundling together the endocrinology services, podiatry services, and any other, as well as pharmacy. This is not in play anywhere in the country. I'm giving you an illustration. You bundle all those types of services together. You will have likely your primary care clinician, who will be the person most responsible for the care of that diabetic patient. They will then work with the endocrinologist and the podiatrist to make sure that that person's care from the specialty perspective is taken care of, that, you know, their medications are regulated appropriately, that they're receiving the foot care treatment that they need to receive based on their level of care. And then they'll really pay a lot of attention to not only the medications the individual is taking for their diabetes, but also other medications that could compromise or impact their diabetic care. What you then enter into is a significant amount of information sharing on a monthly basis to that lead doctor, so in this example, the primary care clinician, that says, here's your patient panel, here's what's happening with them, here's what they're doing, and here's how you can do better. Here's your overall population, here's how your peers are doing, here's what your peers are doing, and really works with them to improve the care of that individual. For the chronic condition example, those do tend to last a 12-month period. I will say that there are fewer chronic condition-based episodes out in the country at this point, and that is just because they are harder to design and more complex to draw those bright lines as to roles and responsibilities. But ultimately, before any episode can be launched and any money can be attached to them, there has to be a very, very clear delineation of roles and responsibilities and accountability.
Thanks, Georgia. We've got a good question about shared savings coming in from an audience member. What have we seen to date in our shared savings programs in Vermont, and what can we aspire to achieve in coming years, especially after the first 3 years of the shared savings program wrap up?
Thank you. So I could probably talk about what we've seen for the next 26 minutes. So I will be brief and say that this is probably a good potential future webinar to do a deeper dive into our shared savings programs to date. So what we've seen so far is we have actually fostered some of the goals we had for the shared savings program. We are seeing more actual integration within and among our clinicians, and we're seeing some early data that shows that quality has improved over control groups within the commercial Medicaid and Medicare programs. We've seen some differentiation among the commercial Medicare and Medicaid programs in terms of both quality targets being achieved or not being achieved, as well as some of the quality measures where we were more successful in terms of improvement versus less successful. And in terms of the commercial and Medicaid shared savings program, we are actually working on a report that provides much more detail about those outcomes that is coming in, should be coming out in the coming months. In terms of looking towards the future, I think we've gotten good information and indication that this is starting to make some change, and that we are making an impact across the state. Moving forward, the state is in conversations with the Centers for Medicare Medicaid Innovation around an all-payer model that would build on our shared savings program. We are still in negotiations with the feds on that, And so the kind of specifics of what would roll out are not yet defined, but those should be rolled out in pretty soon based on the negotiation and the conversation. We'll be able to have a more detailed conversation about the future in the coming weeks and coming months.
Thanks, Georgia. Our next question is about capitation. We've had a great question about how capitation can be sustainable for providers, and in particular, how is capitation now different from capitation 20 years ago?
So I actually almost included a slide that talked about exactly how capitation is different now. So I think there's 3 major differentiating factors as to how capitation is different now than it was. First, we have information, and specifically, we have information that the payers can share, that the state has access to, and that the providers have access to. In the early 90s, frankly, there was a payment made to a provider from usually a managed care entity, and the provider didn't get information about their patient population at the same time. So it's kind of like operating in a vacuum in terms of what was going on with their patient panel. So now we have information that differentiates around that, and part of why information sharing is such a critical component. A second component is, as indicated, building these payment models is a collaboration. This is not something that we do individually, like it's not as if Georgia goes and sits in a room and comes up with a payment model all by herself. So we work with providers, we work with payers, the state works across different departments and agencies to find the right type of payment rate and methodology. That is also very different from what happened in the early 90s, where there wasn't that level of collaboration, nor was there that level of transparency. Finally, there's the kind of accountability and quality measurement. So this relates a little bit to the data and having access to data, but really, right now we are in a place where we work collaboratively to identify appropriate quality measures between the payer and the provider for the services that would fall under a capitated arrangement or under any of these payment models. And we look to make sure that the quality measures are achievable. We look to make sure that we're really truly improving quality or maintaining if we are already of high quality. And we're looking to make sure that we know what the quality is and how it's impacting individuals. So for example, with our shared savings program, we have a patient experience survey that we field. So we know how people are experiencing the system. Again, all of those things about quality measurement were in limited use in the early 90s. So we've made significant strides in all 3 of those areas, and in particular, making sure that we're setting up an optimal system with as much transparency as possible. Additionally, I would say a difference from the early 90s to now is that there's a lot more understanding about how payments impact behavior and how it drives change for both an individual receiving the care and for the clinician delivering the care. And so we've learned that there need to be sub-capitation type arrangements, so payment arrangements between the entity receiving the capitated rate and then those providers who are delivering the services underneath. So again, back in the 90s, there was less of this nuance, less of this understanding of behavior and change and the impact of these models. So we know that if you want to drive, for example, more prevention and better areas of activity, you would provide more resources in a sub-capitated arrangement towards a primary care clinician so that they had additional resources to provide that primary care and prevention services necessary. Alternatively, if you wanted to mimic what Medicare is doing around hospital readmissions, you could say we are going to limit the payment according to certain rules for a hospital readmission, because that is not something we want to have happen in our system, and that could all flow underneath the capitated arrangement.
Thanks, Georgia. Thinking a little bit more about the big picture, can you talk more about who is holding providers accountable, and especially for providers that aren't participating in ACOs? What's that relationship like?
Sure. So ultimately, there's 2 to 4 levels of accountability, depending on the type of payment model you have. So, frankly, one would hope that any individual receiving care, if they are not receiving care that they find appropriate, that they have a vehicle so that they can indicate that they're not getting the right kind of care that they should be getting. So, one would hope that is in effect and has been for many years, that people really react strongly to getting good care or bad care as individuals. Secondly, we have payers who are ultimately have contracts with providers, and there are very specific terms and conditions within those contracts and other agreements that hold the provider accountable. Third, the state has a role in the accountability game. So AHS Central Office, as the Medicaid single state agency, has a responsibility to hold all providers accountable for the services that they are delivering to Medicaid beneficiaries in Vermont. Additionally, the Green Mountain Care Board has significant authority for payment, reform, and delivery system reform, as well as specific authority around payment model pilot programs that they can have, where they can have a very intentional and specific level of accountability. Ultimately, we have many, many tools in terms of the accountability, and they start with quality measurement, and they go all the way up through these kind of larger contracts from both kind of payers all the way through different state agencies to ensure that the accountability targets are met and that there are no unintended consequences.
Thanks, Georgia. Our next question is about pharmacy. So we know that drug costs are a huge component of our total healthcare costs, and this has been an item in the state and national news quite a bit in the last year or so. What are we thinking about in terms of payment reform models that include pharmacy or that might help us impact pharmacy costs?
That's a great question, because this is an area where, frankly, there are some opportunities we have in state with both our Medicaid and commercial programs that are very different from what's available from Medicare's perspective. As I indicated earlier in the webinar, we are trying to do all of our activities on as much of a multi-payer basis as possible. We're trying really hard to make sure that we're aligning across providers, across services, etc. Medicare, because of how Part D is structured, is unable operationally to implement any pharmacy reform for quite a while. I won't even opine on when they can start to enter into those relationships. That means that those pharmacy services are excluded from Medicare's payment models for at least the near to midterm. So that leaves us with opportunities on the state side. We, at this point, for the Medicaid program, we've done a lot of research into what is possible for our pharmacy program. In particular, whether we could expand the services within our shared savings program to include pharmacy, and have not yet implemented that inclusion. And there are some specific challenges with our Medicaid pharmacy program that we have to work through, and that is, for those who are less familiar, Medicaid programs benefit from rebates from pharmaceutical companies. And so any payment reform we design around pharmacy needs to make sure that we are at worst net neutral in terms of the rebates our Medicaid program is getting, so that we don't, again, have an unintended consequence. But we do have opportunity in the Medicaid area. Further, we have opportunity in the commercial area that we could look to. And again, the commercial carriers have more flexibility around what they do for pharmacy and how they can connect pharmacy or not connect pharmacy. Additionally, I just want to note that one of the challenges we have in particular in Vermont around pharmacy is because of the way the pharmaceutical prices are set, volume and number of lives who receive prescription drugs is significant. Unfortunately, we have a pretty low volume because we're a fairly low volume state, a fairly small state in terms of population. So it sometimes disadvantages us in some of these negotiations. And I know that some other smaller states and other legislators from around the country are looking to see if there are ways that they can collaborate across state lines in terms of potential negotiating power or other areas where we can make gains in pharmacy and really help mitigate against pharmacy.
Thanks, Georgia. Let's talk a little bit about data now. How are providers getting data to improve care and measure their performance? And what are we doing to improve that as a state?
Near and dear to my heart, one of my favorite topics. So I'm going to use the example of our Blueprint for Health program because I think it's really kind of a signature example of what we should aspire to do with all of our payment models. What the Blueprint for Health has done is built an amazing health data infrastructure. And they use a combination of data that is claims data, so data about from our all-payer claims database. They look at the clinical data that the practices, the primary care practices, are generating through their electronic medical records. They also have additional data that goes into a clinical registry, and that comes from their community health teams or other providers who don't have, like SASH, who don't have electronic medical records. They smush all that data together in a really awesome way, normalize and standardize it, and come out with information about each health service area, so all 14 of the health service areas. They come out with information that's practice specific, and then really drill down into, hey, why is one region of the state doing so well against a certain quality target, and this other one is doing so poorly? Are there population, challenges in one area that are not in another area? Are there workforce resource challenges? So really letting the data drive the conversation. The Blueprint, at this point, provides that data every 6 months to the practices participating in the patient-centered, in our patient-centered medical homes. And, they're looking to try and increase the speed and rate of delivering that information. So that's one area where I think we've had remarkable success. Additionally, we're looking at faster turnarounds for some of our clinical data in particular. So, as I mentioned, the Blueprint relies on claims data and clinical data. Claims data is slower because of the way the claims processing system works and the amount of lag time you have for any claims system. Clinical data can be updated moment by moment, and we have a pretty strong infrastructure within our health information exchange. We are working very hard with Vital, who manages our health information exchange, to improve the amount of data in our health information exchange and the quality of that data, so that we can use that data for population health analytics that, for example, an ACO or the state might want to do, for evaluation purposes that a payer or that the state might want to do, and also to provide, more up-to-the-minute information to clinicians. In the next year or so, we're going to deploy several new tools that will build on some existing tools that get information, kind of day-to-day, minute-by-minute information in the hands of our clinicians so that they know what's happening with their patient population as soon as it happens. So, kind of an event notification system. All that said, we're not done. There's a lot more work we can do. And I think we, along with, Medicare and the other states that are participating heavily in these types of reforms, have recognized that there's so much potential within the data that we have, collectively, both the state's data and the private sector data, that working together we can really get it to the next level. And one of the hopes that I have is for our Health Information Technology Strategic Plan, which will be released in draft form fairly soon for feedback, and then will hopefully be approved in final form by the Green Mountain Care Board and submitted to the legislature in the spring, will highlight some of the successes we've had to date, but also some of the areas where we can make improvements in the next 1 to 5 years.
Thank you. Can you talk a little bit more about work that we're doing to link clinical care and medical care with community-based population and public health work?
Yeah, so one of the things that we spent a good bit of time over the last year exploring was this idea of an accountable community for health. So what the heck is this thing? Is anyone doing it? In particular, is anyone in Vermont doing it? And if not, how close are we and how can we get there? I think everyone agrees that the reforms we have started, the reforms that are in place, can only go so far towards tackling the social determinants of health And ultimately, you need to really start having longer return on investment strategies and really focus redirecting towards prevention. The idea of an accountable community for health does that. Is it starts to pivot from more of an acute sector, acute kind of medical crisis focus to more of this prevention focus. Our work at looking at accountable communities for health resulted in some really great ideas, and I would recommend to you all the report we released in June of 2015, and set in motion a learning lab for accountable communities for health. Specifically, in the coming months, we're going to be launching a learning lab to really say, all right, we're almost there. We want to, kind of learn from each other where we are, how we're getting there. Are you ready to be more kind of accountable on a population basis? Are you ready to take those steps, each individual health service area in Vermont, towards that? Do you have lots of questions about what the heck this thing is? And really build towards a common understanding.
All right, thank you. We've got about 10 minutes left, so we're gonna wrap up with 2 questions that will hopefully help us get to the big picture of this and think a little bit more about how this is playing out on the ground. The first one is about provider fatigue. We know that in Vermont in particular, we've been working toward various healthcare reforms. For over 10 years, our providers have been experiencing massive change for quite a while now. So is provider fatigue becoming an issue, and what are we doing to help providers kind of stay in the game?
So provider fatigue is a persistent issue. And I think that while we try really hard, we can't totally eliminate that fatigue. We're doing a few concrete things that I think help mitigate against that fatigue. The first is, as I said, we try and have our reforms be as much across all payers as possible. This is, and in particular, because Medicare is making decisions, we try and align as much as possible with Medicare because we can't change Medicare at this point. So how can we work with Medicare's rules and make it kind of minimize the complexity and the burden of different program designs across payers? The second thing we're doing, and this is really, really critical, is working on minimizing the administrative burden to providers. There is, or has been, a proliferation of quality measurement due to how programs grew over time in the state of Vermont and across the country. We are being very, very intentional about looking at quality measures and saying, is this necessary? Is this being measured somewhere else? How can we minimize the burden? How can we make sure that we're getting passive information? So have the quality measurement information passed electronically so the provider does not have to do chart review. One of the really great things that the Agency of Human Services is engaged in is taking a hard look at the quality measurement for our designated mental health system and seeing what they can do to narrow that list, to not say, to make it so that there's fewer measures that they're reporting on, and having different departments and different programs, adopt those other measures as opposed to, having 4, for example, that are related to diabetes when 1 may be sufficient. And so that work is ongoing. I would say that the quality measurement alignment and refinement work will be a continual activity that will require, lots of patience and effort over the next several years, but it's really worth it in terms of, trying to mitigate against that provider fatigue.
Thanks, Georgia. And one last question. The SIM grant has allowed us to design and test a variety of innovative payment models and to start planning for a future all-payer model. How do we make sure that Vermont maintains momentum in this direction when SIM is done?
My favorite question, SIM sustainability. Thank you so much. So I think when we first applied for our SIM grant and we're thinking about sustainability and thinking about what SIM could do for Vermont, so what could this amount of money do to help us? In particular, we were really clear that Vermont was going in this direction. Vermont was going to engage in these reforms, and what SIM enables us to do is achieve our goals faster. We are able to invest in the health data infrastructure at a far faster pace than we would otherwise. But we do actually have ongoing investments in our health data infrastructure. So in that area, we would revert back to those ongoing investments. In terms of practice transformation, I think we, again, had a baseline of practice transformation that we were working with, largely coming out of the Agency of Human Services. And now we have an opportunity to really, we've built up some other structures, and we're able to continue those practice transformation activities into the future. And I think there's any number of places and any number of entities that could foster those type of transformations in the future. Really, again, building on the work we've done today. From the actual payment model design area, I think that we, again, have a baseline of both statutory authorities as well as different departments and agencies that could work together and share responsibility for these ongoing reforms. The fine points and details about what exactly would be sustained versus not are not yet decided. And in particular, I'm looking forward to conversations with many folks, and in particular the core team, about what happens next and where things end up, because we've created a lot of good momentum, and we want to make sure that we're seizing opportunities as much as possible moving forward. Thank you. So thank you all for attending today's webinar, Payment Reform 101. If you have any other questions, please contact me at the email address on your screen, georgia.maheras@vermont.gov. Once you leave today's webinar, as I said at the beginning, you're going to receive a survey on this presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Vermont Healthcare Innovation Project, thank you for joining us today, and have a great rest of your day.